Good afternoon. My name is Doherty. I would like to show you how I perform a shoulder examination, and we will go through the various stages of my shoulder examination. The shoulder is a complex joint and relies upon other joints, and therefore the examination of the shoulder starts not just with the shoulder joint itself, but we have a look at the patient's cervical spine, and we also have a look at the patient's core stability, both of which could lead to shoulder problems, particularly in athletes who tend to throw a ball. So the first thing that we will do is we'll assess the patient's cervical spine, and we do this just through active movements that the patient performs, just a series of tests. So would you mind looking up to the ceiling, and would you mind looking down and back to neutral position? Would you turn your head to the left and turn your head to the right and back to neutral? Would you put your left ear on your left shoulder and back to neutral, and finally your right ear on your right shoulder? So from that assessment we see that the patient has a full range of movement. If we want to assess the cervical spine any further, we can check for any tenderness over the spinous processes. We can also apply axial load to his head to see if there is any tenderness. Cervical spondylosis may give you reduced lateral flexion, movement to the side. The next thing that we would assess is the patient's core stability. And to do this, what we ask the patient to do is to stand on one leg and to do a single leg squat. So if you wouldn't mind, stand on one leg, and if you would flex your knee to about 90 degrees. What we're looking for is to see if there is any instability in the upper body. We're looking to see if the hip drops down or if the knee rotates. And what we saw there was that there was some slight instability, and again, core instability can lead to shoulder problems. Following on from this, the next step that we would do in a shoulder examination is to inspect the shoulder, and we inspect the shoulder from the front and from the back. From the front, what we're looking for is symmetry. We're looking that both shoulders are at the same level. We're looking for any weakness that we may see in pectoralis major muscles, or any weakness around the deltoids. And looking at this patient, there is no obvious abnormality. Pectoralis major muscles look symmetrical. We would also palpate. We'd start at the sternoclavicular joint and we would palpate the clavicle, and we would move along to the acromioclavicular joint. And we're looking for any tenderness or any lumps or masses, and everything feels normal. We get to the acromioclavicular joint and that's fine. We may see some tenderness in the posterior part of the acromioclavicular joint if we have a slap tear. The next thing that we do is we would also palpate the coracoid, which is where the head of biceps inserts into, and we can feel for any tenderness in that area. We may follow the biceps tendon down and see if there is any tenderness, and that's fine. Next, we turn the patient around and we look for any muscle wasting or any asymmetry. We look to see if there is any muscle wasting in the supraspinatus area or in the infraspinatus area. In this patient, there is a slight weakness in the infraspinatus fossa, which may indicate an impingement or a problem of that nature. We would also palpate the scapula and we would check for any tenderness. We'd palpate the border of the scapula and we would palpate all around to check for any tenderness or any problems, and that feels fine. So the next thing that we would assess would be the range of movement, and we'll do this both actively and passively. We would assess normal range of active movement, and we would ask the patient to flex at the shoulder, so we'd ask you to move your hands forward and put them above your head. and then bring your hands down. Then we would assess abduction, and we'd ask the patient to move their hands away from their body, if you wouldn't mind showing that, and put your hands above your head. And we see that we have a full range of movement there. We would also assess movement by stabilising the shoulder joint to assess glenohumeral function. So the way that we would do that is we stabilise the shoulder with one hand on the shoulder, and then we'd ask you just to raise your hand up. Okay, that's fine, and stop there please. As soon as you feel the scapular move, that's the time that the glenohumeral movement stops and the scapular movement comes in. So he has a normal range to about 90 degrees of abduction. We would also assess for flexion, if you would move forward and stop, that's fine. Okay, and come back to neutral. And finally we would assess internal and external rotation. Would you mind moving your arm up here? And if you would just move your hand above. Okay, that's fine. And now move your hand down. So there we've tested internal rotation and external rotation, and the range of movement is fine. So there appears to be no problem there. The next thing that we would look at is we would look at scapular control. And the way that we assess scapular control is we would turn the patient around, if we can just see you there, and what we would ask the patient to do is to shrug the shoulders. We would ask them to shrug them forwards and backwards, upwards and down. So would you mind just shrugging your shoulders forwards, please? Okay, and now if you bring your shoulders back, shrug your shoulders back, thank you, and now if you shrug your shoulders up and shrug your shoulders down. So we assess the movement of the scapula, and both scapulae appear to be moving normally. Again, everything looks symmetrical, there's no signs of any muscle wasting, and the gap between the border of the scapula and the spine is equal on both sides. Next, we'd assess this range of movement with the patient with his hands on his hips. So if you pop your hands on your hips, and if you would just shrug your shoulders forward, and shrug your shoulders back, that's fine. Shrug your shoulders up and shrug your shoulders down, that's fine. Okay, and finally, just to assess for any shoulder dyskinesia, we will do the same movements in abduction. So if you would move your arms out to 90 degrees please, and if you would move, shrug your shoulders forward, shrug your shoulders back, that's fine, shrug your shoulders up and shrug your shoulders down. Okay, there was a slight slower movement on the right scapula compared with the left, but nothing of any significance. That's fine. Okay, if you wouldn't mind sitting down there. So we've assessed for shoulder the range of movements, we've assessed scapular movements. The next thing that we'd move on to would be the acromioclavicular joint. And the acromioclavicular joint sits at the end of the clavicle and is the joint between the acromion and the clavicle. And what we would feel for, we would assess for, we would palpate the joint to check that there's no tenderness, there's no muscle wastage around that area, and we would assess the joint. If there is osteoarthritis in the acromioclavicular joint, you would tend to get some discomfort in that area. The other problem to look for in the acromioclavicular joint is acromioclavicular dislocation, and that may be an old problem or it may be a new problem. And normally you would get a gap between the clavicle and the humerus. To further assess the AC joint, what we can do is we can adduct the patient's arm in that area there, and we feel for tenderness, and again that can be a sign of osteoarthritis, but everything appears normal. Other tests that we can use to assess the biceps would be Yergason's test, and in this test we ask the patient to flex their elbow at 90 degrees and we resist their supination. So we would ask you just to turn your hand over the other way towards me, so your hand comes up, and if there is any pain, then that is a positive Yergason's test. Another assessment of the biceps tendon is to do a Speed's test, and in this we would ask the patient to keep their elbow extended and to put their arm into supination, and then we would resist as they try and flex. So if you wouldn't mind straightening your arm, turn your arm around there, and I want you to move your arm up and resist me. And again, if there is tenderness, that is a positive speeds test. So as we can see from those movements, everything appears normal. Following on from assessing the acromioclavicular joint, the next series of tests that we would do would be to rule out a slap tear. A slap tear is a superior labral anterior posterior tear, and there are several tests that we can do to assess the function of the shoulder. The first series of tests to rule out a slap tear would be to do a Kuhn's test, which comprises of 3 separate checks. The first would be to ask the patient, if you just relax for me, you gently abduct the patient's shoulder, and then from this position you apply downward pressure, and if there is any pain, that may be a positive test, and there's no pain there at all. The second test that we would do is an inferior sulcus test, and basically we ask the patient to sit in a neutral position, we apply inferior distraction, and we assess the sulcus to see if there is any pain or if there is any widening of the sulcus, and that feels normal. The third test that we would do would be a Jurgensen's test that we've already demonstrated, which is resisted supination with the elbow flexed. These tests can be a sign of a slap tear, and if the 3 tests are negative, it's unlikely, with an incidence of about 6% chance of a slap tear. With 1 positive test, there's a 15% chance of a slap tear, and with 2 positive tests, there's a 35 to 65% chance of a slap tear. So they are useful tests to rule out a slap tear. Following on from those tests, other tests that we can do for slap tear would be an O'Brien's test, if we can get you to stand up. And we would get the patient to adduct their arm across, and we would ask them to turn their hand around and point the thumb towards the ground. Okay, if you just stay in that position, I'm going to apply downward pressure. You tell me if there is any pain. That is an O'Brien's test, and that would tell us if there was pain. It may indicate that there is a slap tear. The next test that we would do in the same position is a slapprehension test, and what we ask the patient to do now is to point the thumb up to the ceiling. So if you keep your hand up there and let me press down, and again, if there is no pain, then the test is positive, which again is an indicator of a slap tear. There are various other tests that we can do for a slap tear to make sure that we're not missing any diagnosis. If you wouldn't mind just sitting down for me, that's fine. Now we can do a test. If we put the patient into the externally rotated abducted position, then we can do a test here. Can we just move your hand as though you're going to throw a ball? That's fine. Now a way to assess whether or not there is a slap tear is to ask the patient to pronate their hand. So what I would like you to do is to put your hand out like this, okay? Now in this position, if there is any pain in the shoulder, that is a positive test. A further test that we can do to assess for a slap tear would be in the same position. If you just bring your hand back to neutral, is to ask the patient to flex their elbow to actually touch their head, and we resist that, and any pain in that area would indicate that we have a slap tear. So we've done the test for the slap tear. We can also do a crank test, which would tell us whether there is a slap tear, and we can do a load and shift test. A load and shift test would involve us grabbing the top of the humerus and moving the humerus forwards and backwards. This can be a test for instability as well, but pain may indicate that we've got a slap tear. So following on from the slap test, the next thing that we would try to rule out would be an impingement. And an impingement syndrome occurs through injury or inflammation, tendinopathy, to one of the four muscles of the rotator cuff. The muscles of the rotator cuff are the supraspinatus, the infraspinatus, the teres minor and the subscapularis. And we can assess both or all of those muscles individually. To assess for infraspinatus and teres minor, both of which are external rotators, we would ask the patient to move their arms out with their elbows tucked in, and we would resist that. If there is any pain as they move their arms out, that would be a positive test. If you wouldn't mind putting your hands like this. Okay, and what I want you to do is to push your arms out and I will resist you. Okay, so we're testing there for infraspinatus and teres minor. If we want to assess for subscapularis, subscapularis is an internal rotator at the shoulder, and the way that we would do that would be in the same position. What I want you to do is to bring your hands together and press hard. Okay, that's fine. Now the only problem with that test is it doesn't just measure subscapularis, because your pectoralis major muscles are also internally rotating. So to actually assess the subscapularis muscle by itself, what we would do is we would do a test called the hands-off test. Can I get you to stand up, please? Now, can you put your hand behind your back? And then what we would do is get the patient to put their hands in the lumbar spine area, and then we would ask them just to raise their hands off their lumbar spine. And that's a good test for subscapularis because we're internally rotating the shoulder. Okay, and that was all right. Finally, we would look at supraspinatus, and the test that we do for the supraspinatus tendon is called the empty can test. And what we would do in this situation is we would ask the patient to stand up, if you wouldn't mind standing up for me, and I would like you to pop your arm out, and if you have the shoulder abducted, and we would point the thumb down at the ground, we'd have the shoulder flex about 45 degrees, and what we're going to do is we're going to apply pressure to the shoulder and see if we have any pain. So what I want you to do, I'm going to push your arm down, you stop me, okay? So that's any pain there. So the empty can test, that was negative. If we find that there's no resistance at all, that may indicate a slap tear as well. Another way to assess your supraspinatus tendon, if we suspect supraspinatus tendinitis, is to examine or palpate the shoulder with the shoulder in extension, and we may be able to elicit some tenderness over the supraspinatus tendon. So if we move your arm back, and if we feel just below the AC joint, we can feel a tender area may indicate that we have a tendinitis. As we move the arm forward and flex the shoulder, the supraspinatus tendon goes underneath the acromion, so we can't do the test with the arm in flexion. That's one test that we can do. We can also do a Hawkins test that may tell us whether or not we have a problem with, and the Hawkins test is basically the shoulder is if you bring your arm up there, and let me just bend this arm down, and we internally rotate, and that can indicate if there's a problem in that area. Okay, that's fine. If you just have a seat there. Finally, what we would look for in the shoulder examination is to check for shoulder instability. And the way that we can assess this, we can assess the patient to see if there's any evidence of hypermobility. We would look at the hands, we would hyperextend the fingers, we'd hyperextend the thumb, and we would see what degree of movement we've got, which may indicate that there's some laxity within the ligaments and the capsule. So can I just have a look at your hands? Thank you. So we're just going to try to extend his fingers, and as you can see, that is normal. There's no evidence of any laxity in the fingers. To assess the shoulder for instability, what we would do, the first test would be what we've done before, where we can do a load and shift test, and that will tell us whether or not there is any problem or any increased laxity. We can also apply inferior distraction, as we've done before for the inferior sulcus test, and pull down, and again we will feel if there's any give within the shoulder, and that feels normal. We can also examine the patient supine, so can we get you to lie down please, and we can do a test called a Job's test, which will measure whether or not there is any laxity in the joint. It's also a test that we can use for a slap tear as well. So we will get the patient to adopt the thrower's position, so we will get them to abduct and externally rotate their arm. And what we would do, can you shuffle over to the side of the bed? That's fine. So now the scapula is supported by the bed, and we would grab the patient's arm and we would move forward and back. When we move forward, we may see some apprehension, which may indicate a slap tear, or may indicate instability. And if there is a slap tear, when we apply inferior pressure, pushing down, we should find that the pain tends to go. So that's another way of assessing that. We can also do a crank test, whereby we examine the patient in this position, and we move the patient's arm around, and we can feel for any clunks that may indicate a slap tear or any other instability. Okay, thank you. So that concludes my examination of the shoulder. Thank you very much.